Olivia, you should be able to share. And you should be good for streaming onto our YouTube channel. Give folks one more minute. Almost 20 people joined. Great. So 11:02 going to get us started. I know a few other folks may join today. And just upfront wanted to say, I know there's a few folks who are subbing in. We just ask that those be approved ahead of time. So if there is someone that needs to sub in, please just go ahead and let us know, and DSS can sign off on that as needed. Obviously, things will come up for all of us. In terms of context, I just wanted to say, definitely have heard and we understand there's lots of discussion about scope and also the evidence here. And in terms of at least scope, we somewhat have a focused scope that we've set for this, where it's really focused around primary care program design features. And I think there's a question about things outside of that. And I think there's I think we share at DSS an interest in helping individuals address health-related social needs and drive those, but realize for the context for this is really, where does the primary care space fit within that, and bump up against it without necessarily directly always addressing it, like providing housing through primary care for someone that's having housing insecurity, for example. I also want to just add that we do want to bring some evidence along the way. And so we have prepared to try to do that for today's discussion. And then we've also added time at the end to discuss with the group kind of scoping and evidence and how we're going to go about doing that, and welcome your feedback on this as we move forward. So just wanted to kind of set that up front. Guy, anything else you want to add at the top?
Nope, other than thank you for your participation and looking forward to a good discussion.
Great. Mark, I see your hand up.
Sure. Thanks, Brad. So I wanted to, I guess, make some remarks on having reviewed the materials. My concern that we're still diving into a technical discussion on a timetable that was laid out in the April meeting in a way that I don't think pays due attention to some of the concerns that were expressed in the last meeting about the need for more time, the need to consider what outcomes we're trying to drive, to better understand the performance of the Medicaid program for all members, those who are impaneled and those who aren't, and to really have a chance to talk about the goals and principles that should inform the problem-solving process, just to name a few. And so I heard a real press to spend more time building the foundation for a technical discussion where the thinking about primary care is embedded within a sort of a bigger conceptual frame or vision. And I think the term last time was used sort of so how does this fit within the comprehensive strategic vision for Medicaid, and what is it that would enable, what needs to happen in order for primary care to be fully effective at driving the goals or impacts we might try to drive. So I just want to open with those concerns about the process and about a timetable that doesn't really build in time to address some of the concerns that were raised.
Thanks, Mark. Just we have a couple minutes, I think, with our opening remarks that are pretty brief. So I will just go ahead and pass it to Ellen, and we're going to try to stay on our time schedule. But well, obviously, if we have time for additional comments and questions, we welcome those. So Ellen, let me turn it over to you for a second.
Yeah, I can see Mark's point, and I think it should fit within the broader perspective, but I'm also concerned about the broader overall goals being set in this group. There's a lot of other groups, and, you know, not the least of which is MAPOC, which is the the designated group for strategy for healthcare. So I think understanding that context is important, but I don't think it should be set by this group.
And Ellen, the only thing I'll highlight is we did bring the goals and the strategies that we presented previously to MAPOC, and actually got feedback and adjusted those based off of feedback from MAPOC that we're using kind of as a foundational component before bringing them here. And so that definitely was part of, I can't remember which meeting, it was definitely last summer at some point, and Olivia may remember exactly when, but we did, and we did bring those up because we know MAPOC does play an important role, and we expect to continue to bring information to MAPOC along the way. Michelle, I see your hands up as well. Oh, you're on mute, Michelle, if you're talking.
I'm sorry, I can't get my mouse to work, and I saw that Karen's hand was up before mine too, so I want to go in a proper order.
I must have, see. Thank you. Karen, go ahead, and then Michelle. And again, I think what we may end up doing is trying to keep this to our 10-minute mark, and then if we need to, we'll circle around on this at the end, just FYI, because I do want to obviously get to people's comments, but also try to get through our content for the day. So just go ahead, Karen, and then try to get to Michelle.
Yeah, I'll try to be brief. I really agree with what Mark was saying, in that I think it's very difficult to discuss the details of the payment model without an understanding of what the overarching goals are. And my, review of the research on payment reform suggests that without the broader vision, without a clear sense of how this interacts with other parts of the health system, without thinking about what the infrastructure is for coordination across social supports and medical systems, there is a very minimal to no impact of these kinds of programs. So I think it's really important to take a big step back and rethink what this group is considering and how. Without a set of shared goals, without a set of shared principles, I think it's going to be very difficult to weigh in on the details.
Michelle, let me turn it over to you.
Yes, and I was just quickly going to echo now Mark and Karen's comments about the need to lay a better foundation in order to give us the ability to provide the type of feedback you're looking for. When I reviewed the slides last night and looked at the questions that you were going to pose today, and the feedback that you were going to look for from us today, I don't feel like I can properly give you the appropriate type of feedback that you're looking for, because I don't feel like the proper foundation has been laid. There's still a lot of data that I think that the department needs to give to us, in data that I'm sure that you have collected in order to get us to this point. And it would be beneficial if you took a little bit more time to present that information to us, so then we could have a better discussion around some of these questions.
Thanks, Michelle. Just timing wise, we're just at 11:10. I do want to make sure we can get through some of this, but also recognize this is an important conversation. And I'll just say I will take these comments very seriously and also take them back internally to DSS. I did also want to welcome Representative Lucy Dathan, who is joining as advisor, who some of you may know from MAPOC or from obviously the legislature. And so we just wanted to welcome Representative Dathan as well as an advisor to this group. If that sounds reasonable, we will do our intros, and folks, please just ask to keep comments on hand. We will definitely want to hear from everybody.
So Brad,
Yes.
I'm concerned that I'm hearing from some people, not others who have their hand raised, that it's premature to go into the details of a design model that was just shared with us 2 days ago. And where my understanding is DSS has an abiding respect for data. You are a data scientist and understand that problems should be solved based on data. I'm not seeing anything that's responsive here in terms of a willingness to revisit the time frame or to consider how primary care fits within a revision. It's just, I can't reconcile proceeding now with a review of the technical merits of certain care delivery redesign straw proposals with the fact that I'm hearing that folks don't feel the foundation has been laid. And so it's completely at odds from what I'm hearing from members of the group. And I just don't know how to reconcile that, because it doesn't seem to me that you can have a technical conversation and not have a conversation about the data.
I just will add, I think one of the challenges here, which I will definitely recognize, is that as part of the process leading up to this, we did spend a fair amount of time reviewing prior data in terms of programmatic evaluation and outcomes, and spent most of last year doing that, which I recognize that we didn't spend a lot of time reviewing that as part of this process. So I do want to just acknowledge that that has not, we sent around the information, but it's a lot of information. And also, I recognize that sometimes it can be helpful to have time to discuss and review collectively to help set some of that. So just to say, we obviously have spent a fair amount of time last year, even gathering new data from focus groups, others on primary care, but recognize that we haven't done that explicitly with the time in this group. So I just wanted to at least highlight that was part of this process. And some of you, I think, were more involved previously in that than others, but that we haven't collectively discussed. And the same for setting kind of goals and priorities did also try to do that as part of the process last year, including really through the MAPOC Care Management Committee, and bringing it to this group. But obviously we haven't spent time talking about here and kind of socializing that and confirming that I think at least even if there's not consensus, that there's understanding about what those goals and priorities are. Guy, I don't know if you want anything else to add, or if that's
Thanks, Brad. I think maybe the only thing I'll add, and seeing some of the comments in the chat, bunch of comments and listening to them carefully. I know Brad is as well. One thread is on sharing information out, the data, which is Brad saying, I think is important, and we can do just very procedurally. We can't do that today because we don't have the slides teed up, etc. But Brad, one thing we might consider doing is having a separate session offline where we spend more time, and we could record it so if folks can't make it, with the data, the analytics, the kind of the problem that we're trying to solve. I think that's part of what I'm hearing. I'm also hearing a bit of a maybe less data and more goal, or kind of more normative discussion. So let's take that back and think about how to address those concerns. But I definitely think on the data kind of sharing out, I think that's straightforward, and let's figure out the best way, whether it's the next meeting, whether it's a separate meeting, whether it's a recorded presentation or something. Let's figure out the best way to make sure that we're setting the context and sharing the data so that everyone's on the same page.
So Guy and Brad, I'd like to make a proposal, but I would prefer to.
Mark, I'm sorry to do this, but just there are a bunch of people who have raised their hands ahead of you. So I'm gonna hand it back to Brad to be the moderator, but I just want to make sure that that folks we're kind of respecting the order of the meeting. Thanks.
And so Mark, let me get to the other, and then we'll put a pause and just make sure folks get to talk, and we'll take things a little off of the schedule. So I think next up I see Angela, and so I just want to pivot to Angela and maybe one thing we should do actually before we do this is just do our brief intros for those who didn't get to first, and then we'll just kind of put a pause in this schedule, just because I want to make sure those who didn't get a chance to say hello previously. We actually, I think we're going to Josh maybe isn't on from the comptroller's office, I think. So Mark Maselli, I think, is. So Mark, do you briefly want to just say hello and introduce yourself, if that's okay?
Hi, Brad. Thanks so much. Mark Maselli, President and CEO, Community Health Center. I think most people know we have a statewide primary care system with close to 200 locations provide primary care. This is our 51st year of operation, and we also are engaged in a number of other activities that have us focused in on research and education. Good to be here.
Great to be here. Great to have you. Thank you. And I think Josh is not able to join us. I know Doug is actually seeing patients again this morning, and time wasn't working for him. So I think actually that's it in terms of, I know we have a few folks that are on representing some of our other committee members, but we'll move forward and actually hear from folks who have their hands up. So Angela, sorry again, if you want to jump in.
Yes, good morning. Angela Harris from the Phillips Health Ministry in Hartford. Just wanted to get a better understanding of how this group will be operating. I've served on the cost growth benchmark technical team. We have minutes to meetings. We, have lively discussions. We also have, the video. Relying on a video is not something I like to be able to capture action items, and so we can hold ourselves accountable so that when we move forward, we know that we have met our own objectives. So last meeting was my first meeting of this group. I know you all have been working in previous capacities. I'm new, so not having a place to go to get all the information in one spot puts me at a disadvantage to getting caught up to speed, but not understanding that last meeting you asked us what our priorities are, and those are not outlined anywhere. How do we know that we're meeting our own internal expectations as well as the community's expectations, for improving outcomes? So I just want to know, how does this body work so I'm not having the wrong expectations? If someone, I'm not sure how you all are operating, who's running this, but if someone could share that, I would definitely appreciate that. Because right now I'm, having gotten something 2 days to jump right in and to not have captured what we talked about last meeting. To me, like, when you start a meeting, you accept the minutes and make sure everybody's on the same page before you go to the next step. And I don't see that we've done that.
Thanks. And there's some information from the last meeting, but it sounds like maybe that wasn't helpful. We'll take that back internally to address. Let me go on to Josh and then Robin.
Thank you. So just to remind everybody with a quick intro, I'm a physician. I'm a family medicine physician. I've been in practice in Stamford for 23 years. I am currently in practice, so clinical practice, but I have another role that is the Chief Medical Officer for operations for Stamford Health Medical Group. My hand went up kind of at the same time as everybody else's, really with a concern for the timeline, Brad, as you were talking about. But I think that the timeline of the agenda for today is representative of the timeline that we are trying to achieve as a goal. And I feel rushed. I feel rushed right now for this particular meeting. I feel like we're not going to be able to stay on point. And I also feel that that translates into the timeline that has been presented. And whenever, I guess my role here as a physician is to be the voice of a physician, and that always makes me want to pause and make sure that everybody is on the same page. We have aligned goals. We have a mutual timeline that is respected for everyone. And there's a comfort level that goes with it. And based on the comments that I was just hearing, I don't feel we're in sync. I don't feel there's comfort level with the timeline, with the plan. We don't do this in medicine. We really look at a lot of effective treatment plans and then adopt them. And so I correlate that with this type of timeline, and I'm not seeing it, and it raises concern for me. Thank you.
Thanks, Josh. Robin?
Good morning. My name is Robin Anderson, and I am the Executive Director for the Ministerial Health Fellowship, which is an advocacy coalition that advocates to address health disparities and also the healthcare concerns of people of color throughout the state. And I am also echoing what everyone else is saying, that I really don't feel that I'm on the same page. I really don't feel that the foundation has really been laid, and to be able to go along with the goals and to proceed forward when I'm not sure what the foundation is in terms of the direction that we're going in. So I really hope that we would pause and that we would take this opportunity to, really help all of us to be on the same page before we proceed with something that seems to be already outlined with, prior to us coming together and meeting, but we don't have the ins and outs or the foundation of how we got to where we are right now. And so I'm not sure how I can proceed with something if I don't know, how we got to where we are now, and that we feel that we're ready to move forward when the foundation has not been laid. Thank you.
Thanks, Robin. So just want to acknowledge everyone's, I think, comments and feedback so far. And I think what we can do, one is just the procedural one is we're going to look into making sure we have some minutes to making that easier for folks, and then also having an evidence discussion. But I think what we should do for today is pivot to some of the slides from last meeting, have discussion on some of the goals that had been laid out as part of some of the work that was done last year. I think that sounds like that might be part of a foundation that could be helpful to, that we could spend some time discussing as a larger group, just make sure there's some, if there's concerns or alignment on them, and we can spend some time reviewing that now. And I think Olivia and or Tiffany, if you don't mind pulling those up, I think that could be helpful. I just want to confirm, Robin, I see your hands still up. I just wanted to see if you had anything else you wanted to add. And if not, and Rob, I don't know if you heard that, or I didn't know if you had any other questions or anything else you wanted to add. All right, if not, I think what we'll do is pivot again to those goals that we discussed last time and have a discussion on them. That sounds like maybe a helpful foundation for us to talk about. And let's start there. So we'll just take a second to review these, because I think, as everyone's kind of alluding to, needing maybe a little time to digest and also provide comment, and then we can discuss them as a group. So one, I'll just say it out loud again. These are just as a reminder, these were done last year. Again, these were based off of feedback that some of the data-driven feedback we pulled as part of the work that Faulkner helped us do, as well as focus groups on primary care. And then we developed some end goals as well as strategies, and brought those out and did get feedback and actually modified them based off of feedback through our care management committee through MAPOC. And so this should be open for discussion. Let's take a pause, review them. I'll just say the end goal, I'll read it out loud. Sometimes just helpful to hear it. Improve the biopsychosocial health and well-being of our members, especially for our most historically disadvantaged members, in a way that reduces inequities and racial disparities, be fiscally responsible, sustainable relative to the no reform baseline. Any increases in primary care spending should be offset by savings from improved member outcomes and not by restricting access to service. You see, Jim, your hand's up. Feel free to jump in.
Thanks, Brett. And so I appreciate going back over these goals, and they're all great aspirational goals. Where I'm struggling is moving to what we were going to discuss today is specifically, there is a wealth of problems that are going to influence all of that. And there's not a single solution that's necessarily going to come to be brought to bear. Excuse my voice, what you need to do to solve access may be very different than what you're trying to do to improve equity, which may be very different than what you're trying to do is improve cost and raise it. So the challenge is we brought forth, as I looked at the deck, a fairly comprehensive care coordination sort of, we know we need these resources, but in my mind, we haven't decided the specific problem that's supposed to solve and how we're going to deck against what resources we need and how accountable that people are going to be for the specific sections of improving the biopsychosocial health and well-being of our members that we're trying to adjust right now, because that's so broad. It's like we're going to take a little bit, and I'm not being overly critical, but a fairly standard care management model. We're going to put care managers in there. We're going to have people calling and making sure they're checking in. We make sure people have rides, is sort of the example. But we're going to need some specific pieces that need to be fixed first and second and third as we go down this. And all of those will have different needs for different resources and capabilities that we're looking to develop in this program. And I just don't know how we translate these very broad, aspirational, and absolutely supportable goals down to the very specific tasks that we need to do, and therefore deck resourcing against them. So that's where I'm struggling.
And so do you have any suggestions in terms of how to address that from what would be helpful to see from your vantage point?
Well, I think it gets a little bit to, so as we dig into what are the problems, it's not a problem. There are a host of problems that we're trying to address. We've still got to say, what's the data telling us as to where we've got the barriers to address inequities in X, Y, or Z? And figure out what are we going to do and deck against that if that's our top priority, because we can't do anything, I'll make it up. We can't address the needs of the underserved unless we create access. It's all well and good to sit there and say we're gonna hire a bunch of people, but if that's our main barrier, that we've got an access to care problem, that requires a certain amount of groundwork to make sure we have the capacity to get these people seen in the right way in the right place. I don't know what our priorities are. I don't know what specific part of improving the quality, affordability, and equity of care that we're going to tackle first. Yeah, because I don't know that putting care managers in an office is going to necessarily address the fundamental problem, right? Because I'm not sure I understand which is the most essential, the highest priority.
Thanks, Jim. Welcome others' thoughts on this, and just of note, I didn't tick through the strategies that were listed here, but obviously this may be a starting point for us. But I think, Jim, as you said, like what's some background information or data that could be helpful to understand what those priorities might be? And I think as mentioned, we can talk about some of the data that has been collected that may inform some of this. And so I think that could be helpful as part of this conversation.
Karen has a hand raised.
Great, thanks.
Go there.
Yeah, I think similarly, I think I was struggling to connect these goals, which feel pretty aspirational and interested in innovation, with the focus on such a narrow scope of change in the program, and with the lack of a vision for community clinical integration, right? That's what a lot of these goals are really about, is how do you connect community-based services, wraparound supports with what's happening in the clinical setting. And because of the way Connecticut's Medicaid program is set up, we don't have the infrastructure or the coordination tools that some other states do. There are a number of innovative solutions being put in place in other states to address that gap. I think it would behoove us to think about how to do this in a way that really is going to create improvement in health outcomes, and not just in a very small way shift a little bit more attention to care coordination. And so I was I was feeling a disconnect between these goals and what was in the initial straw man. It feels much smaller in scope than I was hoping for. And I don't see it being particularly high impact unless we think a little bigger about how to fix some of the major problems with coordination across systems, communication across systems, data sharing, et cetera.
Karen, one quick response and thought there. First of all, thanks for your comment. Part of what I heard when we got here was that folks didn't feel aligned on the goals. So one question I might have for you and for others, I don't think these goals are just up motherhood and apple pie. Like I think there's some real specific things here. For example, on any increases in primary care spending should be offset by savings. For example, the focus on member choice and access, the focus on testing and learning. And so I guess one question I have both for you and more generally, before we move off of the goals to solutions, I do want to make sure that folks are aligned on these. And if there are things that we think are missing or that you disagree with, I'd like to make sure we outline those first, because on the previous comments, it felt like folks were saying there's a disconnect between lack of alignment around the goals itself. So anyway, I just wanted to say thanks for coming on the solutions, but I do also want to make sure we're on the same page on the goals before we jump to the solutions.
I appreciate that. And I think an important point that came up last meeting is that I heard, and this could just be my bias, but I heard a lot of consensus around focusing on improvement in outcomes and acknowledging that savings will come from that, right? If people are healthier, the program will spend less, but not to lead with the savings, and to really focus on shared accountability for health outcomes as the overall goal. And I do think that that's what those solutions get at, right? I welcome other folks correcting me if that was not a shared understanding.
Let me pivot to Alice.
Hi, thank you. Clifford Beers has been working on this problem now since 2014. I sent out our wraparound results, and I don't want to go to a solution, but I think that we did look at the data and the cost outcomes, related to a wraparound model for 1,800 individuals on Medicaid in Connecticut, and it included adults and kids. So it was a whole family model. I think that, what we didn't impact was as important as what we did impact, right? So what we were not able to control for or actually have any impact, matter of fact, went up, was ED utilization. And so we put in a couple of solutions to try to reduce ED utilization. One of them, which was a person in the primary care clinic to follow up on who of our clients was in the ED the night before and check in with them. But I think that, inpatient utilization was reduced by 50%. And we also focused on health education and we using the PAM as a measure for people feeling able to control or navigate their own healthcare. So I think that all of the goals that you have are important, but one of the things that I think is going to be really critical is getting out of the office and really building a community-based model that is almost from a community organizing point of view as well as a informational point of view. I think the vaccination program from Yale was a good example. We were not door knocking and sending people, to get vaccinated. And I think the rates were lower in terms of equity deaths in the New Haven region. So I don't know. I just think that as we talk about this, it's going to have to be really out of the box, out of the office, in the homes, in the communities, in the schools, to be able to really, make the impact that you want to make.
Thanks, Alice. I think, Paul, I see your hand up.
Boy, this is a hard conversation. we've been studying primary care in Connecticut for a long time. I just pulled up a document, Mark, a SIM document that looks like it has goals that are similar to kind of what we're talking about here from 2018. And in the meantime, has anybody tried to make an appointment with a primary care physician lately? I mean, it's hard to do it in the commercial space. And I can only imagine what it's like in the Medicaid space. And so, and in the meantime, kind of our spending, kind of the cost growth benchmark report found that we were only spending 5% of healthcare on primary care. So, I'm frustrated with this conversation. I feel like, again, we've studied this to death, and we need to start making some progress. As I look at this study guide, kind of if you jump into it, the straw proposal discussion seems to me like that's a good place to start. I mean, the questions there are, what philosophy, kind of how does everybody feel about these different approaches? And from there, it seems like the next step would be to develop something that's more specific. I'm hoping that we can take action, and I respect everybody else's opinions. I talked to my primary care physicians friends, and they're struggling with kind of all the pressures that they have, and kind of the lack of capacity. And I don't know, Joe, Jim. I mean, kind of we need more primary care physicians in Connecticut, and until we start kind of rewarding them better, we're not going to attract anyone.
So just one, and I'm going to quickly pivot to you in just a second here. Just want to make sure that on these specific end goals and strategies that have been outlined, like if there's one, or is there anything that's missing here? And I think definitely, Karen, we heard your commentary, I think, before on the piece about outcomes versus fiscal component, but just want to make sure that others can weigh in if there are any other, what's right here, is there anything that seems to be drastically missing? Would welcome that as well. So Ellen, let me pivot to you.
I share Paul's frustration, and I was excited actually today to get into some details, and I looked at this as more informational, not that we're going to make a decision today on the care system, but it's interesting to me to look at what others are doing, to reflect on it. And I'm not going to agree with I'm not going to be all kumbaya, trust me. But when I look through it, and yeah, Brad's nodding, I know, Ellen. But it's I think, and I get the point of, if you start in the wrong place, you'll end in the wrong place, and framing is really important. But I also think getting into the weeds and how other groups are doing it, some of them well, some of them not so well, I think is a place to start and might help us with the framing as well. Just my thoughts.
Thanks, Ellen. And definitely we've tried to pull together a pretty diverse group of folks with different interests and backgrounds. I do want to pivot to Mark and then we'll go. Yeah.
Thanks, Brad. So in looking at the end goal on the left, improve the psychosocial health and well-being of our members, and especially our more historically disadvantaged members. So the question that for me is not, I guess that's important to consider in assessing strategies, is whether we're genuinely committed to improving health versus better care outcomes for sick people. Much of what we see in Medicaid in terms of avoidable negative outcomes as a result of how many people get sick, that is the drivers of poor health. So when we did the SIM work, which Paul alluded to, DPH presented data that showed near epidemic levels of diabetes that were predominant in the low-income population, and where there were stark disparities between African-American, white, and Latin, Latino, Latinx. And so my question really is, to what extent is our focus coordination of care and access to care for people who've gotten sick versus figuring out how primary care and other methods can be used to actually address the contribution of the increasing prevalence of chronic disease. And then related to that, with regard to strategies, I'm wondering what the role of the community is, the numerous community supports and entities that are essential for enabling individuals to succeed in life and work and health.
Thanks, Mark. Jim?
Thanks. Paul, I couldn't agree more. So, we, and don't take, improved funds, revenue flowing to primary care is an absolutely imperative goal. The challenge, though, that I struggle with, we built a good deal of this model. I have care managers in all the offices. We have pharmacists, we have social workers, we have doing all of that stuff, and we've been doing it for a while. We are just as constipated, and it's impossible to get into our practices with all that resources as you guys are. And so, and this is why I'm saying we got to make sure we define what specific problem we need to solve first a little bit, because I don't think care management is going to open up a tremendous amount of primary care space. It's going to take a very different approach to kind of get to that. That may not be what we should be doing, but it's really that detail, because I think we put there are some real challenges to recruiting primary care into the state. We know that they have lots of places they can work, and they are the foundation of everything we're trying to do has to be anchored back to our primary care docs. We're finding the only way we can create that capacity is building out more robust teams than care management people, but we've got to take work off of their plate and constantly looking at how do we not make them, we talk a lot now, Paul, about primary care as a service, not as a doc. And there's all sorts of components that getting them comfortable to offload work that they don't essentially have to do. So it's not a bad start. It's not a bad model. I have completely embraced the model. We've actually built it and been doing it for a while. My question is, again, when we're talking about a really precious dollar that's coming out of Medicaid, because those dollars have to spread pretty far and wide, are we really being thoughtful of leveraging the reality of our environment, all of the assets that we have, and making sure we're dovetailing that we're getting the most bang for any investment we're making here as we support primary care and how we direct those funds? And I'm just not sure I can clearly articulate that I understand that piece. And I guess that's where I'm struggling with as a first step. This isn't going to be solved with one new model. It's just not. But the goals are absolutely mom and apple pie. It's a question of how do we actually make it execute and be successful. Otherwise, we're going to find ourselves back here saying, well, that didn't work. What are we going to try next?
Thanks, Jim. And I think Robin, your hand was up, and I just wanted, I think you, or sorry, actually, maybe I missed that, but I thought I saw your hand up at one point.
Yes, and I mean, I just kind of really echo everyone, and even as I look at, I do think that I'm just not sure of what as I think about addressing the healthcare concerns, not just today, but even in the future, and to actually reduce the gap of persons of color living not living as long as our other counterparts. And I look at some of these goals that we have. I don't think that it's really encompassing all of that and really looking at ways that we really can address health disparities, not just today, but also to eliminate them even in the future. And sometimes I feel like I'm starting starting a place where I think there's some other things that, should have happened in between. I'm not sure who were part of the focus groups and who were actually part of that, but I don't feel that this is representative of the community that I serve. Thank you.
And just to push from, I just want to make sure I'm getting that right. In terms of the, on the specific goals and strategies, you said we're missing something here? Just want to make sure I got that. And if there is something missing, what, do you have anything specific you think we should have as part of this?
I think that, again, I think it all goes back to where we're starting from. I think that, just in terms of, to me, being able to actually really review the data and really know, how the data, where the data came from, and then to really be able to develop a plan. I don't feel like I'm at a place, also that I see based on the data that I don't know that you're working with versus the data that I know about in terms of how we came up with these goals.
Sure. So I'll just say, I think definitely hear the request to kind of review data, and we will kind of talk with the DSS folks on here in terms of how we can operationalize and make sure we get a separate probably meeting together to discuss the data so that we can make sure that people have a chance to look at it, talk about it, understand what was pulled together, how, and even as well as the focus groups. Because I think as many of you said, that would be a helpful place. And obviously we do want to make this successful. We want folks to feel like they're, we're hearing what they're saying, which is hopefully what you're seeing a bit today, as we are trying to hear that. And so we appreciate the feedback as we're going along.
Yeah, so my question is that I know you refer to the term as underserved, but I call it people that deserve to be served. In terms of thinking about those things that they may need, or some of the outcomes that really are current right now or have occurred, versus what are some of the outcomes going to be to address some of those needs of people that deserve to have those, to have insurance, to be able to get into primary care doctors, to be able to the best health care that they can get. So because I don't know the framework in which you're coming from, it's hard for me to really be comfortable with these goals. And also, who came up with them? How did you come up with them? And who was at the table?
Yeah, so just to reiterate, like these were kind of made in light of some of the data that was gathered. Again, we will review that together, and the focus group data, which did include some member focus groups, as well as providers, community advocates. And then we did bring this to MAPOC for further refinement and feedback. And so again, we do welcome feedback. And if there is things that are missing, or, we would love to hear that. I think we want to set a reasonable ground, a base, so that we're at least trying to address a similar issue. I think as Ellen had said, we don't expect group consensus of everything. That's going to be impossible. But we do want folks to know where we're at least starting. I think that's an important piece. And I think what we're definitely hearing today is we're trying to take a step back, even in this meeting, to kind of reground a little bit, and then try to get some of again, spending some time maybe talking about the data for those who really want to delve into where this is coming from. And I saw a hand raised from Angela, so I do want to quick pivot there.
Yes, for the sake of time, I've left some of my comments again in the chat. Just really curious to know the data around access to care, like the operation hours of providers. And as we look back on the pandemic, what we cannot forget is that many folks who never knew they were essential workers were called to punch the clock so that the state could keep going. These same people, many of them are working part-time jobs, multiple part-time jobs, and they don't necessarily have the luxury to go to a primary care preventative annual physical exam in the middle of a Monday through Friday 9 to 5 schedule at the convenience of the physician, and not be able to punch that clock and pay their rent before they go to their second job. Okay, so we have to understand who we are serving. The systems may have to adjust what and how and when they are providing access. Many communities now have the urgent care pop-ups everywhere, except in those communities that have large numbers of people on Medicaid. We don't see those in our community. So we wonder why ERs are used, because people don't have access. So until we address and have the systems actually meet the needs of the community, the biosocial health and well-being of our members are an afterthought. And it's got to become the priority if we're going to get there.
Thanks, Angela. I don't think I saw it. So again, just while we're on this, really wanting to pin down a little bit that, and I think I heard, Robin, obviously you said you're just concerned a little bit about where these are coming from and how they're informed of it, which want to be respectful of that, but also wanting to identify if there's anything that seems drastically missing as part of this, which, I think is obviously, I think, Jim, one of the things you said is these are maybe still relatively high level. I think there is some concreteness, but obviously, and I think Ellen and also Paul, what you had said is that sometimes it helps to dive into details to know, like, are these some of these conceptual things actually potentially addressing, do they actually get to the meat of what we're trying to do? And so sometimes having something concrete to weigh in on can be useful, which is somewhat how we had anchored today, was like to try to delve into some of those details. Do some of these strategies around care management actually start to address any of these? And how do we think about framing it? Understanding that based on feedback today, we're going to try to we're taking a little bit of a step back, trying to revisit these goals and strategies, and then also thinking about how we can provide the underlying data and information to you all to make sure that we're starting at the same place. But let me pivot. I see, I think
I do have a follow-up a question. When you share the data, can you also give us the background metrics on, like, your number of people in your data set, who they were, where you were, the numbers of folks involved, so that we can assess the magnitude of how this information was generated?
Well,
and specifically what communities, I just.
Can I offer quickly on that front, just as we're talking about the data?
And if that's posted somewhere, if you could just share the links. Again, new to the group, trying to get caught up, and all of this, you can make data say whatever you want it to say. It's called spin. So I just need to know the background information of where all of this is coming from.
Great. Totally appreciate the point. And I just want to offer to folks in terms of the data and where that is coming from. We did send out with the first meeting materials, there was an appendix that you all should have received. That provides a high-level overview of both the quantitative data with all of the sourcing for that information, as well as the background around the focus groups in terms of who participated, how the outreach occurred, and what the findings of that were. So I would certainly encourage you to take a look at that and let us know what is missing from that. But that is a sort of starting point here, in terms of understanding the data, both, quantitative and qualitative, that inform these goals. So certainly welcome, if there are holes in that, but take a look at that. There's quite a bit more underneath that. We tried to provide a fairly concise version to this group, recognizing you probably didn't have time to go through a 150-page report, but we can certainly bring, you know, more in if there's a desire for that. But that's a good place to look, at least as a starting point, is at that appendix that was sent out last time, and we can resend that as well.
And then, Robin, your hand was up again. I don't know if that's legacy hand or if or not.
No, oh, sorry about that. I'll put it down.
Oh, no worries.
Thank
Tiffany?
you.
Hi, good afternoon, everyone. Tiffany Donaldson with the Connecticut Health Foundation. I've been listening carefully, intently to this conversation. I appreciate the feedback that everyone has given. I think where we are today is that the primary care goals that have been outlined, I agree that we need to understand where there has been appropriate community input and feedback. But overall, I think we all agree that this is the why we are here. So to improve the, biopsychosocial health and well-being of our members is a goal that I believe all of us are coming to this table with agreement on. And that is what I'm hearing, other than trying to get a better understanding of what is the sources of some of these strategies that have been outlined. Which it seems like the data will be able to show us, or the understanding of the past committees will be able to show us where that's coming from, but the goals seem to be very clear. Where I hear a lot of struggle is around the what are we going to do in order to address these particular goals. And what we were presented today was jumping right into the what and how we're going to do it. And so there has to be a balance of the two. There has to be a balance of understanding what we at this committee are here to accomplish. Brad, you keep alluding to other work that's been done in the past, what they are there designed to accomplish. There needs to be an understanding of how this big goal that we have is being accomplished through the work of this committee, through other committees, through other work. Also, a better understanding of whether or not the models we are setting forth are addressing all of these issues, some of these issues, what is the scope of what we're trying to accomplish, and how can we get to this huge goal if we're focusing on narrow solutions? How are we going to get to it? Perhaps there are others who are working on other solutions. I think there needs to be an understanding of how this committee, the work that we're doing, fits with the broader context of how we're going to get to this goal. And then even in looking at the models, a full understanding of whether or not these models are going to accomplish the scope of what we are here to accomplish. So as you are going back and thinking about what we do going forward next, I think it's important for us to understand, again, a lot of what we are grounding this work in. So a lot of the background information that you said that is available that you can provide. I think we need a better understanding of how Medicaid defines psychosocial health, because it may differ from some of us on this committee, and it seems like it may differ if I look at some of what was outlined for today. So clearly understanding that and seeing if we can get some consensus around what that means for each of us. And then to understand what we are doing, where are we accomplishing some of these goals, and how is it happening across the state?
Thanks, Tiffany. Polly?
Hi, everyone. Polly Vanderwood, Executive Director of Population Health at Yale New Haven. Piggybacking Tiffany, I appreciated your comments. Looking at the materials today, I think a couple other things kind of stood out to me. Is really, we think about primary care access. There's also access to community resources that did not seem to be addressed or kind of potentially kind of postponed. If we think about the needs of addressing the biosocial needs, the health-related social needs, how do we think about building capacity within community organizations, within some of the programs that DSS offers, how many of the Medicaid members might take advantage of certain other services that DSS provides. So I think there's a community capacity component that we would need to be thinking about. And then in addition to primary care workforce challenges, I do